This episode of the Psych to Practice podcast is sponsored by PAR, where psychological assessments meet innovation.
PAR has been the gold standard in the industry for over 45 years and has empowered professionals in education, healthcare, private practice, and research with trusted tools and cutting-edge solutions.
Discover more at parinc.com. Again, that is parinc.com. Creating connections, changing lives.
Welcome to the Psych to Practice podcast, your one-stop for practical and useful clinical information, masterful insights from experts in the field, and a guide to daily living. I'm Ray Christner, and with me,
Paul Wagner.
Paul and I had a great opportunity tonight to talk with Dr. Marie Hooper, who is a psychologist in Canada, who brought a topic that we have not had the opportunity to chat about before, and that's Pathological Demand Avoidance, or PDA.
For those of you who are unfamiliar, as myself, kind of towards the, really before we got into things, PDA we're identifying as a kind of a profile specifically for individuals with autism. And it's not brand new, but it's certainly something that isn't identified or really talked about all that much.
Yeah. And I think, we're probably hearing more about it, I think, on social media and through kind of, different informal outlets. But I think it was really interesting to really just hear about, how it has maybe some similarities, but really some differences with what we see with oppositional defiance, where it may look that way. But, I really appreciated Marie's kind of explanation of kind of these core kind of features that help us maybe differentiate when it really is more of a threat response than it is just a behavioral manifestation.
Yeah. For those of you who are unfamiliar with Dr. Marie Hooper, she's the co-founder of Flourish Health Service, a neuroframing clinic providing comprehensive assessments and therapy for autistic individuals and those with complex profiles such as pathological demand avoidance. She serves on the board of directors for PDA North America and is the co-creator of Autism Reframe, a clinician-developed course that equips mental health professionals to deliver affirming care for autistic clients across the lifespan. As a late-diagnosed autistic and ADHD clinician, Marie integrates lived experience with clinical expertise, championing strength-based, trauma-informed, and relationship-focused practice. Her work centers on creating supportive environments where neurodivergent individuals can thrive and on training the next generation of clinicians in neurodiversity-affirming approaches.
And for all of you listening, definitely with this topic, interested in your thoughts, if, join us on social media. And if you have some feedback or some information that you'd like to share on this topic, we'd love to hear from you.
And with that, we hope you enjoy this practice in action episode, Understanding PDA and Hard to Spot Autism.
Marie, welcome to the Psych to Practice podcast. Thank you so much for joining us from Canada.
Yeah, thank you for having me.
Absolutely. So we're kind of excited because we're talking today about a topic that we haven't done before. So in 3 years of the podcast, we haven't hit upon anything related to the topic. So I'm gonna let you introduce it here in a little bit, but we'll just so people know, this is the first time we've done it. So before we get started, we always like to have our guests tell a little bit about them so our listeners get to know them a little bit. So we use the term origin story. Kind of what got you into psychology. Tell us a little bit about how you got here.
Yeah. So, well, first, thanks for having me. I really appreciate that. And I think PDA is such an important topic and something that we really don't understand a lot about. So I'm happy to be here. I think for me, started working with kids when I was, super young. I was 14, always worked with autistic kids, didn't know at the time I was autistic myself. and was absolutely drawn to working with kiddos and adults who struggled with, social cognition and things that sort of, I guess when I look back, it was me reflecting on my own struggles, as a young person. And so I think my journey has really been both professional and personal. And so I find it, I guess I'd say it's my special interest. I founded this clinic in Toronto in Canada to be truly a neuroaffirming clinic, a space where autistic folks like myself and many of my staff and those with complex profiles like the one we're going to talk about today could be understood and supported without pathologizing, who they are. And I think that being a mom of two kids with complex needs as well really solidified that this was the right place for me. This is what I needed to be doing in my life.
Wow. Okay. And that's, it's so this is something like maybe a little bit of a calling throughout your life, but really didn't know. Like, it sounds like you learned about your own neurodivergence after you became a psychologist. Is that right?
Yeah. So I had a bit of a journey, much like so many of our clients, our adult clients. Earlier today, I spoke with a young person, 25, and, she told me about how, she struggled in university and she kind of dropped out and she went back. And that was sort of my journey. I struggled at first to kind of get it right, to be in the right classes, to really sort of being able to advocate for what I needed. At the time, I didn't even know what I needed. Yeah. When I got more serious about, school and was able to really sort of focus on what I wanted to do, then I did my bachelor's, my master's, and then my PhD. And now I'm in my supervised practice year. And so I only was diagnosed last year. So I had finished my PhD. Wow. But there was a reason I was so interested in it. There was a reason why I was so called to these hard to spot presentations in autism, PDA. I seem to take things a little bit further always. And so I'll give you just a quick example of, how important this was to me in my journey is that, I've been following Limpsfield Grange, the school in the United Kingdom, only school for autistic girls in the world. And I didn't just meet the headmaster online. I flew to the UK to have a meeting with her for 30 minutes because I wanted to do it so badly.
Wow.
And now we're this close to our first pilot here in Canada, to doing the same thing and recreating what they're doing there. And so I'm really excited about that.
Wow. That's fantastic.
Yeah. For all the kids who just weren't seen early on. Yeah.
Yeah. Yeah, absolutely. So you had mentioned we're going to talk today about PDA. Mm-hmm. So pathological demand avoidance. Although lately I've been hearing kind of a little switch into the term of pervasive drive autonomy instead. Mm-hmm. Are those used interchangeably now, or is there a preference one or the other as we're talking about it today?
Yeah, so I'd say that, PDA, pathological demand avoidance, is the more clinical name, although as many of us clinicians know, it's not diagnosable, it's not diagnostic, right. It's not in the DSM. But, PDAers, and I am one myself, certainly prefer to drop the pathological term. Sure. I would say, it's really that description within autism. And so pervasive drive for autonomy or persistent drive for autonomy is sort of where PDAers and their families, they use that language.
That language.
Yeah.
Okay. So tell us, when we're talking about PDA, maybe for our listeners who are not as familiar with it, mm-hmm. what does that actually mean? So what is it? And, you had mentioned that, it's not diagnosable, but it is part of autism and the autism presentation. Tell us a little bit about it.
Yeah. So I'd say it's really sort of this sub-profile within autism. We use it as a way of explaining how people's nervous systems respond to the world when things feel out of control. In PDA, even small everyday requests can feel super overwhelming. And I'd say that it's, it often presents, or the clinical reason or the referral reason to get an assessment or understanding this profile is really through oppositionality. And I'm using my air quotes there because, it looks like defiance. And so often I'll get kiddos that come into my office that have ODD diagnoses. And really, unlike ODD, which many of us don't like to diagnose anyway, it's really this idea of like fight or flight. It's not about, that stubbornness or that oppositionality. It's about safety. A child or an adult, although I don't see as many adult PDAs, their brain reads a demand, anything from put your shoes on or can you tell me about your weekend, as sort of a threat to autonomy and independence. And the body reads it in the same way that it would to danger, like fight, flight, or freeze, or now, in more, newer literature, the fawning. And I think what makes it look different from other autism profiles and why it's so distinct is the variability within the profile. So some might seem totally capable and confident one moment and then hit a wall the next. The thing that I think throws people off with PDA is the inconsistency. Parents and teachers, clinicians, because it's like, it looks like a choice, rather than sort of a nervous system overload.
And when you're identifying that, like, what are those distinctive pieces that you're looking for to really kind of highlight and recognize it as this profile here? Because it can be inconsistent in that, and when it's being activated, it sounds like. So how do we kind of strengthen that awareness of like, okay, yes, this is PDA that we're seeing and not something different?
I think one of the things that, we see at our clinic here is often the referral when kids get here or when their parents are inquiring about assessment. It's often about those kids who are not at school. So that was where we really start to see that breakdown. And there's 6 core features that we kind of look for within the PDA profile. And that first one is that intense need to kind of avoid those everyday demands. So yesterday, Johnny was able to, let's say, get ready for school and he was able to get to school. But today it's an absolute, fight or flight moment. One of the challenges with PDA is that kiddos don't know if they're being chased by a golden retriever or a saber-toothed tiger. And that is how I frame this to parents when I'm speaking to parents, because I think, it's always, well, not always, but often it is, they were able to do it yesterday. I kind of feel like I'm walking on eggshells. I never know what the response is going to be. And it often looks like I won't do it. But there's a true saying within the PDA community is can't, not won't. And that's how I like to reframe that for families.
So when you're working with parents, and I'm assuming you have parents who they're thinking maybe for at least some more of the oppositional piece.
Yeah.
And how do you differentiate that? Where it like, what are the things maybe that you look for or questions that you ask that help you kind of go, no, this is a can't instead of the won't?
Yeah, very great question. One of the most common questions. I think it's one of the most misinterpreted profiles because it can look like ODD or, oppositionality, but it's because of the resistance and the power struggle. So the overt behavior, what you see on the outside is that, right? Like, tantrums and meltdowns and all of the things. But with ODD, we know that the behavior is usually deliberate. With PDA, it's driven by fear. It can also look like ADHD. I've gotten some recent referrals around, do you diagnose, PDA within the autism or ADHD profile? And the answer is no. We don't have enough data around that. Also, we don't diagnose PDA.
Right.
But, it can look like ADHD because of the emotional intensity, the impulsivity. But always, I think the thing we always go back to is how these behaviors stem from a threat response, not attention regulation. The thing is that so many of these folks, by the time they get to us, they're in burnout, right? So it looks like depression, it looks like chronic anxiety. And so these folks are ending up with many labels that don't necessarily fit. And I think that the challenge is, clinicians often, we don't have enough information about this particular profile. And what I think happens is that we're assigning treatment plans and labels to the wrong profile. Behavior charts, rigid routines, the consequence-based systems, all of that we would use in general for autism, those increase that sense of threat. And what happens is it backfires.
Right.
And so that's how we often will know that that's what we're dealing with.
So I just want to make sure I kind of heard that right. So you're saying like in some ways, the response to the intervention can also help with the diagnosis, that maybe someone has tried some behavioral intervention plans that can be very effective for a lot of kids. But with this profile, it's not only not a good response to intervention, it actually exacerbates the symptoms that we're trying to extinguish.
Oh, 100%. That's exactly it. PDAers are looking for that relational safety, that flexibility, collaboration, kind of how you would treat trauma. We're looking for co-regulation and declarative language, which, many of our speech paths, will work with our clients on. But for the most part, it's co-regulation and safety rather than this like compliance-based, rewards-based programming that generally does work with our neurospicy kiddos.
And you've mentioned like there's 6 core features that are there. And I know you started kind of like labeling some of those, but I just wanted to circle back around to those. Were there any of those that didn't get identified, or when we're talking about that, like, does that feel like that's the main area, or like those features really are that the nervous system response that creates the fight or flight reaction because it's this perceived threat piece of it?
Yeah. The more pressure kiddos feel, the stronger the avoidance gets. And so the more they feel under siege or under attack, the deeper this gets. And so we have many kids that I'm working with are just not in school at all because they've been forced to go back. They've been forced to be put in this environment that's completely overwhelming for them. I think one of the other differences, with PDA that's just, often why it can be missed is how strong these social strategies are. These kids are clever. They use humor, negotiation, distraction, charm, all of the things. A child might say something like, okay, let's make a deal. If I brush my teeth, you have to do the dishes, or tell a joke to derail the conversation. And adults often describe this, like parents, like they're too smart for their own good. I can't tell you how many times I have that quoted in my notes, but really it's an attempt to stay safe through connection. And so when we're wondering about that, autism proper profile, often those social strategies are an area that we identify as an area for growth. But with PDAers, it's stronger. Their social strategies are stronger. I think the other thing is like that strong need for autonomy. We all love autonomy. We all love dependence. We all love to be in control of the things that we love. We like to be in control of ourselves and the things that we do. But things have to feel like their idea. So if you say something like time to start your math, they're going to resist it instantly. You're going to get a wall up. You're going to get, no, I'm not doing that. Likely a meltdown or some other form of resistance. But if you say, I wonder how you want to tackle your math today, that kiddo might lean in. And it's really all about preserving agency, which is so different in our, typical autism profile that so many of us clinicians, so many of us know and understand.
And now a word from our sponsor. PAR's AI Report Writer is an AI-boosted tool that generates comprehensive reports, including interpretations and recommendations based on scores from a wide range of popular assessment tools. Spend less time on report writing and more time supporting students. Learn more at parinc.com/AI. That is parinc.com/AI. And now back to our conversation. So I just want to go back to and make sure I kind of heard this right. So like when I think of PDA, I think in my mind, I've always thought of it as it's this intense resistance to the task. But how you described it is that's maybe it, but there also may be a more socially savvy way to avoid the same task. This isn't that you always have, like, we may have somebody that's not throwing temper tantrums, but is very skilled at diverting from the task and still avoiding it. Am I hearing you that right?
Yeah. And I think one of the, when we're doing some of our diagnostics, we often ask about kids who lie or who fib, right? Often autistic kiddos usually have trouble with that. Our PDAers they're very skilled. Stomach ache, they can't go to school. The somatic symptoms start coming out, but just in general, like they're quite good at manipulation.
And when that nervous system piece of it is being activated, is there any, I guess, conversation or research about what creates that perceived threat? And is there a consistency throughout their environment? Or in terms of like that autonomy element of it, like how does that get discussed, especially for like younger children, like in like working with parents, like, because it really sounds like it's rolling out so many different areas before landing on the PDA piece of this. And like, I wonder like what an early identification would look like as those resistance or avoidance techniques are being developed. Like, how do we catch this early?
I think, especially like in our kinders, our younger kiddos, that choice and flexibility are everything. If you think about how you might talk to someone who I hate using these words, but like someone who's moody, right? Think about how you might tiptoe, right? I'll be honest with you. Many of the parents I work with say things like, I feel like I'm walking on eggshells at home. Like you might see a child, like young children, I'm talking 3, 4, 5 years old, who's calm and chatty one moment, and then suddenly shouting or sobbing or having a meltdown the next. And the little thing that shifts is their sense of control. So they're not choosing, obviously, to be volatile. Their nervous system flipped in an instant from regulated to threatened in mere seconds. And many families will describe this as, we didn't see it coming. And when I look at functional assessments sometimes from, schools, when parents come to me, they said, oh, we had a therapist come or we had an OT come. Often there's no trigger.
It also makes me then wonder, like, with part of the treatment or part of that, like the approach that's there, I do hear the nurturing environment of reducing the perceived threat to autonomy. Is there an element of joining in and sharing autonomy, or like that to me sounds like that's that, like, how do we then improve our ability to be adaptive or flexible in those moments, especially if not everyone or not all environments are going to then be aware or kind of hold that space? Is that a part of that approach as well in terms of providing support, or what does that look like?
That's the best question. And the number one question I get from educators. We treat PDA as trauma assumed, from a trauma assumed lens. Trauma and PDA interact in really interesting ways because we know that trauma obviously doesn't cause PDA, but it shapes how it shows up. When someone's nervous system has been living in chronic stress, which is how this feels like, even if there's been no traumatic event, their threshold for feeling safe gets lower. And even the small demands can feel huge. And so the more that builds up, the less tolerance a person has. And so you see this sort of loop. The person avoids a demand, feels relief, then guilt, then faces another demand. And the cycle just really sort of spins and repeats itself. And from the outside, this often will look like volatility. Parents will say they should be politicians. There's like manipulation involved. And I use that word lightly, but that's often how parents feel, right? But really what it's coming from is this idea of like pure survival. And so I had a client, a psychologist I consulted with the other week, who mentioned that, we were talking about PDA, and she said, "You mean challenging behaviors?" And I said, well, it's not intentional. Yeah, well, but it's really challenging behaviors because the child will not comply. And if you're a clinician who's working with clients like this, and that's how you're thinking about your client, then we need to do some more work.
As you were kind of describing it, it reminds me a lot of Ross Greene's work. I don't know if you follow like Ross Greene's like collaborative problem solving type kind of approaches. Is that some of like the lens maybe you view Like, because when you use your language of how you like say things, I'm like, oh, that reminds, like that's what triggered in my head of
that is
what I hear.
Exactly it. So
okay,
there's no data on this, outcome data, very, very limited outcome data.
Yeah.
And I'll be honest, folks, like I am embarrassed when I write a report. And I am under supervision. I'm in my last year writing my licensing exams. And when I am talking with my supervisor, my clients, I am embarrassed by the lack of recommendations that we're providing for these families. It's the PANDA approach. It's the co-regulation. Oh, buy the book. Here's the website you can go to. But we really don't have that outcome data. And so CPS, Ross Green's model, is one of my top 3 recommendations when I write these reports, because you're giving choice and autonomy and you're letting the child be part of the problem solving.
And he does have some pretty decent data. So, right? he's at least, probably more than we see in a lot of other approaches. So, yeah, interesting.
And many parents feel good about that, right? And so they feel like they can, they at least can get behind that. Yeah,
I agree. I just want to circle back for a second, because I just want to make sure it's clear for our listeners. We started talking about those 6 core features, and I just want to make sure. Can we call those 6 out specifically so that we can kind of make sure, like, I want to make sure they have it before we move on to other things. So go over those one more time for us, the 6 core features.
Sorry, I'm all over the place.
No, you're good. That's
okay. So number 1, the most obvious one is that intense need to avoid everyday demand. So again, like we can look at, this can be refusing to get dressed, procrastinating on homework, suddenly forgetting how to do something that they did easily yesterday. That's always the big one where parents are like, I don't understand. It's the body really saying, I can't do that right now. I can't meet that demand. The more pressure they feel, the stronger the avoidance gets. The second one is social strategies to manage these demands. And this was the example I gave around, like, if I brush my teeth, then you have to do the dishes. It's like this negotiation. And parents often will say, like, I've got a master negotiator. It's like with a sweet little smile when they say it, or there's like a real, sort of plan behind it and how they do, negotiate. The third one is around big mood swings tied to pressure or loss of, control. And so you might see a child, again, like who's calm, super chatty, really engaged, and all of a sudden now they're shouting or sobbing, and there's really no antecedent. You don't really know what the trigger was. And the shift happens because somehow they perceive there's a threat that they've lost control. The fourth one is the strong need for autonomy, feeling in control of the things that, obviously in the moment they're wanting to resist, or they might resist those demands instantly. So feeling like they got to choose when they left for school, they got to choose what they were wearing, or, I gave the math example. What they're really trying to do, the underlying sort of mechanism, is preserving agency. The fifth one, and this one is really interesting because it's, sort of comfort in imagination or role play. We see this, it's less so in, more typical presentations of autism. So it's the fantasy worlds, the costumes, the characters. You might see a child who doesn't speak for themselves, but will happily sort of answer as a fictional character or an animal. And it's this idea of like, I have many cats. So I work with a lot of girls and assign female at birth kiddos, and many cats who come into the office, and the cat will speak to me, but not the client. And then the last one is around the intense and focused interest. We know this in true autistic profiles that can be really common, but really it's the child can become very fascinated in power dynamics or in movies, or fixate on how friendships form and break down. It's just more socially themed. So those are some, slight sort of core, those are some core features. Again, we know it's not a diagnosis that we're making and that we're describing this profile within our reports, but these are the things that I look for.
And this is just, I think, a bit of my lack of, I guess, maybe exposure to this. But in hearing this, like there's so many pieces that align with that, it's kind of the typical presentation with autism. And then there's so many that deviate. And so what makes this a profile for autism and not something like either standalone or in and of itself? Like, how did it end up being attached to autism here?
So that's a really good question, one that's asked all the time. And again, we have some short sort of data around that. And it was, what's her name? Elizabeth Newson. And she was a developmental psych in the UK. And she was working with all these autistic kids who happened to be more social and verbal, but they were showing much more extreme anxiety-driven avoidance of everyday demands. So they weren't responding to these traditional behavioral approaches, but yet still meeting criteria within the criteria A and the B. Obviously, it's changed since 1980. But the point is, it was really rooted in this need for safety and control. Then coined this term, pathological demand avoidance. But as I said, we don't love the word pathological, but it's a very distinct social difference within the autism profile.
And I guess based off that that social difference, does awareness of a PDA alter the presentation of it? Like if an individual is self-aware and recognizes, okay, this is something that I experience, does that allow for there to be maybe more cognitive work done to like reframing some of those experience threats? Or is it experienced so distinctly as a nervous system, like as that perceived threat or that experienced threat in that way? Like in some ways, my thought goes to like exposure and like treating anxiety elements of this. Is that a part of the treatment process at all?
What's wild about that is that you can barely get these kids into a treatment room.
Yeah.
Getting kiddos to assessment is difficult. Often, I'll be honest, I've never seen more burnt out parents than the parents of kiddos who are experiencing this. Our clinic recently brought 12 moms to a retreat of many of folks that had been been experiencing what it meant to, live with kiddos with PDA. And, we had moms that hadn't slept off their couch in 2 years, hadn't been away for such a long period of time because of how demanding this can be and what this feels like to live with, at home, a kid who's really struggling getting to school and, eating, getting dressed, all the adaptive skills, all of those things. So getting them into the therapy room is almost impossible. So we're working with parents around caregiver burnout. That's how we spend most of our time. And our recommendations are allowing this child to recover from burnout before we try again of getting them back to school. And what's happening where we are, in Toronto and, in Canada, is that these kiddos, if they've missed a certain period of time, they're just being de-enrolled from school without calling parents. And so it's where these parents are in a tough spot right now.
It sounds having a system that is automatically identifying and reacting without really ever that exploration of what's truly going on and trying to meet their needs in that moment or in that way.
That's right. And because, in my opinion, because so many of these kids have these social skills that we don't see in, that typical autism presentation, they're not identified as autistic. It's only when they get here or when, we're doing interviews and, pulling out that ADOS, which I don't love, but, doing the things that we need to do to make that diagnosis. Often the schools and, educators will change their reframe a little bit around understanding that profile. But it's hard to come back from once you're seen as a child who's been defiant and oppositional and fleeing from school and a parent that doesn't make her kid go to school and all the stigma that goes around with that. And
you'd mentioned about like kind of this difficulty in sometimes identifying. And so can you talk a little bit about the masking effect when it comes to, I'm thinking just PDAers in general, or maybe autism in girls, like how's masking play a role in this whole dynamic?
Okay, now you've asked the question where you're going to get the hour-long answer. Because this is the thing I spend the most time talking about. So thank you for asking such a question. I'll be honest, the masking and the camouflaging is the reason why PDA flies under that radar. Many autistic girls or AFAB, assigned female birth kiddos, PDAers in general, learn to copy what's expected. What is going to get me out of this situation safely? It's the tone, the gestures, the right rhythm. Our PDAers are studying human behavior more than our, autistic proper kiddos. They're often funny, they're charming, they're chatty, but underneath, they're tracking every social cue like a high stakes chess game. Okay. I would say 13, 14, by that time, they're completely exhausted. They've learned that this good behavior that they've been doing earns safety. So, if you've met anyone who masks, they hold it together in public. And you folks know as clinicians that we often see a discrepancy between what the parents are reporting is happening at home versus what the teacher's reporting. And often how these kiddos are presented at school when they're older, girls in particular, is model student, perfectionistic, no issues. You see no elevations in any of the questionnaires you've given, yet parents are describing something completely different. And they get into your office and day one, it's perfect. You're like, how did this kid even get here? Why are they spending this money? And then day two comes along. And the more comfortable they get, the easier it is to see. And so I think there's inconsistency, but it's where they finally feel safe to be able to release that tension. And so we don't do 1-day assessments at this clinic because of the areas we look at. We do 3-day assessments, 2 hours every day. Because by day 3, I've seen the mask come off. Usually, it hides that distress, and PDA in particular, that mask is protection. But when you feel comfortable, you're letting that guard down.
So I'm curious. So in the 3 days, mm-hmm. you're able to kind of, for lack of a better word, help the mask come off, unmask the PDA. What makes those same students go to school for days at a time and that mask never come off? Like what is it that you do that creates maybe the environment to allow that mask to come off?
I think it's a couple things. I think we're asking the questions that are about the child's experience rather than their behavior. What is happening for you internally? And I get, kids who are crying, first they're resistant and, doing, the thing. But when you're asking these questions, like, what's it like for you? When you're asking about their internal experience, 8 times out of 10, I've got a child who responds. 2 times out of 10, I have a child who's swearing at me and throwing things at me. But more often, I've got a kid who knows they're struggling and they want help. And feel safe enough for whatever reason to be comfortable here. But again, I've had things thrown at me many times. And in most of these situations, if there's a 2-parent home, 1 parent is home now and has left work completely. And so there's often a pleading that's happening in our waiting room. Be honest with her. Tell her the truth. Tell her what you're experiencing, how hard this is for you, which is a demand. But by that time, they're usually burnt out and have been missing school for, months at that point.
You notice, is there any link in terms of like genetic predisposition for this profile? And so like with that parent that's either staying home or the parent who isn't, like, are they also able to connect or recognize any of like past traits or past experiences that they've had in a similar sense or in a similar capacity?
Well, you folks know when you're doing, your neurodevelopmental assessments and you're doing the interviews and the parents are saying, I was filling out those questionnaires. That feels really familiar to me. And often, if I'm being completely honest with you, I assess a child and then I have a parent come back. I assessed a grandma recently as well, because that feels very familiar to them. I see that with autism. I don't see that as much with PDA. So I don't really have an answer for you there, because I see that much more with like an autism hard to spot profile, but not necessarily PDA.
And I guess that also makes me wonder, like, prior to the identification of PDA and like, starting to develop some of these approaches to help support, support PDAers, what did outcomes look like? Like, when they were going through school or when they were going through this experience, like what ended up happening for them, and how did they end up adapting, or what was that response like? Any ideas there?
The adults that I work with will often say that they ended up in a psychiatric hospital with a psychiatric crisis, if I'm being completely honest with you.
Yeah.
I get a lot of burnt out folks who have had difficulty holding down jobs because of their inability to attend every day, asking for specific accommodations that they wouldn't get or didn't even really know they needed, if I'm being completely honest. Again, we don't see as many PDA adults or that name it PDA, but the ones that we do see are in chronic burnout.
Is there with the idea that we're not seeing as many individuals in adulthood, is there a developmental progression that some of the regulation behind PDA, do we see that just as people mature, they've developed more coping skills, or what's the reason why? I mean, I know with like other things like ADHD, we'll see it change with development. Is there a similar pattern here with PDA?
Oh, that's a beautiful question. Yeah. So we see that there's folks that are not working for companies. They're working for themselves, like myself, right? Like learn to cope in a way that was like, this is not sustainable for me. This is not manageable. I can't be under threat all the time. And so those are the ways that I think if you've got the cognitive strengths there, I think you can manage and white knuckle and kind of work around it. But any PDA or adult I know talks about how difficult that was and things that they had to give up in order to be functional.
Yeah.
And at the risk of their mental health.
That also leads me to wonder, like in terms like the impact of the relationship itself. And so do you notice, is there a different presentation depending on the individual who's providing that demand or that directive that's there? And in terms of what's being activated or how strong or just different ways of that response. So if there's a strong trust that's developed and built, does that help to build resilience and almost distress tolerance in a way?
It's a wicked question. It's an awesome question. I would say frontline parents get it the worst, right? They're the ones, even though they've developed that co-regulation, who are you more comfortable with than your mom, right? To like, let it go. I hear that all the time from parents. They fall, the teacher says it's amazing. They open the door and they spill into the door and they're an emotional wreck. So that for sure is a relationship I have come to understand. And it is often, if it's a heterosexual couple, it is often the mom who's staying home. And so I see that a lot with mom. What I do see is punitive approaches or old like teaching approaches that really go back to this consequence model. You got to stay in for recess because you weren't doing this thing that you were supposed to be doing. The kids who are being praised. So anytime a child is praised in the classroom with a PDA profile, that is not received well. So because it's a demand, it's an expectation. And so I hear from parents that kids who have teachers that do that a lot often feel the wrath of this more, who have sort of more old school approaches, sticker charts, reward charts, those sorts of things. Whereas an EA maybe who has a more attunement and more co-regulation skills tend to fare better with these kiddos.
And is there ever a transference that's noticed, like in terms of like developing social relationships? And if there's a demand that's being observed elsewhere, does that ever activate, or is it truly only more so their own experience of a demand, or that direction that's there? Any experiences there?
It feels very individualistic. It doesn't feel like it feels very much to the person, but I can't say for sure, mainly because by the time these families are coming to me, their child has been home for a very long time.
Yeah.
And so it's hard to know, all the competing factors in an environment because they're not in that environment anymore. These are kids that parents will say, when I talked about the mom who, has slept only on her couch for 2 years because her child played video games all night and she had to be at work in the morning, but he wouldn't let her be away from her. And so these kiddos are often up all night on video games or screens because that's the thing that's going to keep the peace.
Yeah.
So, given this, I know one of the things I'm sure listeners are really probably wanting to know is, what do you do? So as far as like for clinicians and for educators, like what are your recommendations about how do we reduce the demand pressure and how can we support autonomy better to help these kids and I guess adults in some cases have greater success in those environments?
When these kiddos are, and I say kiddos because I work so much more with children who
Sure.
have this profile, is that, recognition that's really early. I would say do not fight the burnout. We're not going to keep trying to make a kid go to school that is resisting and is coming home every day and kicking and screaming and all of the things, because the more that happens, the harder it is to get them back once they go into full out burnout. And that's always, because in our regular sort of, evidence-based approaches, the longer you're away from school, the harder it is to get back, right? We know that in school avoidance and school refusal literature. But for these kiddos, if you go back too early from burnout, it's like reversing 10 steps. And that is very difficult for parents to hear. What do you mean? They have to stay home longer? Yeah, because you have to recover first before you can, because once you go back to school or to work or whatever it is, that threshold is now smaller and little things are even smaller now that can tip the scale. And so that's really hard for folks to hear usually. It's like, actually, our plan is for you to stay out of school longer. We're going to try and, do these small exposures and all of these things, but only when it's safe to do so and only when kiddo has a say in the plan. So is there a way to catch it before it gets to that point? So, one of the things, as I'm sure questions that would come up is, in the US here, staying out of school is very difficult. And parents have fines levied against them. And there's a whole bunch of other things that could come about. So before we get to that point, what are some of the things to do earlier when some of these kind of features are emerging that might avoid that complete burnout piece? I've recently joined the board of directors for PDA North America. And one of the biggest things that we're doing is pushing these educator modules that there's a new education sort of platform that they've introduced, because we are not recognizing this early enough. Yeah. As you know, as clinicians, these kids are not coming to us at early days. It's just anxiety, and the difference is, and now what's happened, sorry, just to go back for a sec. Now what's happened is we have so many families who come and say, I think my kiddo has PDA. The difference between PDA and like school avoidance is the extremity, how extreme this is, how what I tell parents and what I tell educators is only use a trauma assumed model. We're not guessing here. We are assuming that there is a trauma response that's happening, and we go from there. But again, by the time these kiddos come to my office, we're past, like, these kids have missed school. There's no early detection. And that's because nobody knows about it. So we really need to do more work in understanding hard to spot profiles as a field. Schools investing in this type of work for teachers. The prevalence rate, is 1 in 31 for autistic kiddos. And we need to recognize this. We need to be teaching how to recognize these signs earlier.
And I recognize exactly what you're saying is that we don't have that model yet. We don't have that information. And I guess more so like subjectively, like, are there any things that you look out for, or even, I don't know, like if there's like sibling interactions that, like, with the kiddos that you're working with, that, where it is identified, potentially identifying other elements of that, like, hey, how do we learn from this and, try to catch it or recognize it with, again, whether that's siblings or in other areas, like, what do you think they could look for, even if we're right now is just your thoughts through your experience here?
Yeah, so I'll talk a little bit about just the girl presentation, because that's the area I work with the most. Yeah. How, again, these are the perfectionistic, the models. If a kiddo is really into dogs, really into reading, these are pro-social things that we don't think as atypical or off, right? Like these are things that, I have a kiddo recently whose special interest was cleaning their room and cleaning everyone's room in the home. And no parent is going to say, like, that's, we should get this checked out. This is great. Reading in girls, right? Repetition of books in series, perimeter of the, walking the perimeter of the play yard. Are they integrating play? Or girls are often have one really good friend that they hang on to, or they're on the periphery of a bunch of different friendships. So when you ask that question, do they have friends? Yeah, they've got friends. Okay, well, tell me about those friends. And they're often much more acquaintances than anything else. And so with hard to spot presentations, it's really the depth of these scenarios and these experiences. Eye contact. Many girls make eye contact. As a clinician who identifies as autistic, who has had an official diagnosis and an assessment, the number one thing I have in my office is, but you don't look autistic. You make eye contact, you gesture. I study human behavior for a reason. This is, I've learned this. I'll hear, parents will say, well, they make eye contact. It's because they've been taught to make eye contact. And so all these like subtle little nuances that I've got, one little kiddo who, teacher says they can't be autistic. They're really smart and they engage in the classroom materials. But they tell everyone what to do and how to play. And they line up the iPads on the carts every day because that's their job and what they want to do. So it's these little differences in these repetitive behaviors that I think many folks don't necessarily recognize as are obese.
So for those clinicians that are maybe trying to differentiate PDA from other conditions during assessments, are there any tools or anything that you would recommend that they explore that can help them in that differential process?
Yeah, great question. I think the EDE, sorry, let me just go back for a second. I just want to make sure I get this right because they've just renamed it. The EDAQ, and it's the Extreme Demand Avoidance Questionnaire. It's one questionnaire. That's not going to tip the diagnostic, scale into yes or no. But when that kiddo is in front of you and actively avoiding in a pleasant way, usually, that's one of the things I, will look around when I'm thinking about formulation. But that extreme demand avoidance, that's a good start, a good place to start. And, You'll know it when you see it. Let's put it that way. So we start off with that questionnaire. We're asking about what school, getting transitions, what all of those things are like, but also how are they in a day-to-day? And if you get a parent that's describing walking on eggshells, today they could do it, and yesterday they couldn't, or whatever, vice versa, you're likely looking at a PDA profile.
Well, as we're kind of wrapping up, we like to always kind of have our guests end with answering a couple just questions that we ask everyone. And so I guess as, for our listeners, if there's one kind of piece of content, whether it's related to PDA or just something you're interested in related to kind of the field, whether it's a book or movie or whatever, what's something you'd recommend people look into?
Ray and Paul, I can't do just one. I have PDA, and so I can't just give you one. I have to give you two because...
Okay, I will take it.
I'm going with two. So Donna Henderson's work.
Okay.
And I think she's been on your podcast before, I want to say.
No, she has not yet.
We talked about it recently. So soon, you have to have her.
Okay.
Her book is This Autism with Sarah Weiland. It's the best piece of literature, I would say, as anyone new who's diagnosing or looking to diagnose. She's got the best questions, and we call it the Donna around our office, the interview question, the hard to spot presentation. And then the other one is Low Demand Parenting by Amanda Dykman. That's another book that I highly recommend.
Great. And is that second book something that is appropriate to recommend to parents as well? Then,
yeah. The first one to clinicians, the second one to parents, because Amanda writes about her own experiences as a person with PDA and her experience with PDA.
Mm.
Yeah.
And our wrap-up question is if you could kind of give maybe 3 takeaways that you want our listeners to remember, what are the 3? And if you want 4, we'll give it to you.
No, just 3 this time.
Okay.
So safety always comes first over anything. That regulation piece is huge. Number 2, connection matters more than compliance. With these kiddos, you are going to need to sit with them in the hall while they have a meltdown and sit through it. Many parents will tell me that they've learned patience through this process and like how parenting looks different for a kiddo like this who's experiencing these this presentation. And then the last piece is autonomy is not defiance. It looks that way, but we want to understand what's driving the behavior, not the symptom.
Great. Wonderful takeaways. Well, thank you so much for sharing with us kind of your expertise in this area. Really appreciate it. And again, glad to finally have this topic on the podcast. So we really appreciate you taking time out of your schedule, which I'm sure is busy working with a lot of kids and families. So thanks so much, Marie, for being with us.
No, thank you. It was lovely. Thank you.
Great.
And just one more time to echo that, thank you, Marie. It's really it kind of helped to shine a light on something that I really wasn't super familiar with. So truly appreciate that. And if our listeners are interested in learning more or staying up to date with what's going on, where can they follow you at? Or, what are some good resources that they can really check out for themselves?
Yeah, so we just launched Autism Reframe, which is a website for clinicians who are working with autistic folks or want to learn more about neuroaffirming care and therapeutic modalities and how to adapt therapy for working with folks across the autism spectrum and the life spectrum. And then you can also be found at flourishhealthservices.ca.
Certainly hope they take you up on that offer and they're able to really kind of expand their expertise or even building awareness of this for themselves and helping to support just the identification and, again, building autonomy, not compliance here.
Thank you.
And absolutely. And if you're a licensed clinician who would like to use this information, please head over to www.psych2practice.com, or you can check the show notes for a link to purchase the accompanying exam for continuing education units. If you're interested in hearing more or staying up to date with what's going on for Psych2Practice, you can visit our website at psych2practice.com, or you can follow us on all major social media by searching Psych2Practice. We'll be back in 2 weeks, but until then, be well, stay psyched.